This is the syringe and needle that I use for the initial intradermal anesthesia. I use a 5 cc syringe. The reason a 5 cc syringe is that I don't want to create a xylocaine toxicity or lidocaine toxicity. And this is one of the biggest risks of a local anesthetic procedure. Too much lidocaine is used. The following formula is what I deploy. I deploy one bottle, that's 50 mils of 1% xylocaine, 1 in 100,000. That's one 50 ml bottle of 1%, 1 in 100,000. We then take normal saline and mix that together with our bottle to give us 100 cc's of 0.5%, 1 in 200,000. Just give me the bottle or container. To that, we add one last thing. So this is our mixture right now. In this, we have one bottle. That's 50 mils of 1%, 1 in 100,000. We've mixed an equal volume, 50 mils of normal saline, giving us 0.5%, 1 in 200,000 in this graduated cylinder. Then we add 20 cc's of 8.4% bicarb for 120 mils. Now, why 20 mils of 8.4%? In the plastic surgery literature, there's some evidence that that 20 mil in that dilution amount gives the optimal buffering of the pH and minimizes the pain and discomfort. So we end up with 120 cc's of about 0.48%, 1 in 200,000. What that gives me is about 120 mils of solution. And as I infiltrate, you will see I use this 5 cc syringe and I do a tumescent tunneling technique. And if I use about 10 to 11 of these on each side, I will use about 50 to 60 mils on each side, or 120 mils on both sides. At 0.5% xylocaine, an average 75 kilogram person, respecting the 5 to 7 milligrams per kilogram toxicity, so with epinephrine, let's say 70 milligrams, you can use approximately 150 cc's of xylocaine. That's 0.5%. You can use about 75 mils of 1%. By diluting it in half, you can get away with about 150 mils. I usually use about 120 cc's of 0.5%, which still gives me 30 mils of leeway. So by diluting, you do not compromise anesthesia. You still get a good vasoconstrictive effect. In fact, probably up to 1 in 800,000, you get adequate vasoconstriction with the epinephrine. So I would caution you about using too much xylocaine. There is a risk of toxicity. In your environment, in the side office, you should still have the ability for IV access. You should have the ability for intravenous Valium in case they seize. You should have resuscitation equipment. CPR should be part of the certification criteria of your staff. You should have a defibrillator. And a recent ACLS should be present with one of the physicians in attendance. And I think that will keep it as safe as possible for your patient. So once you've got your 0.5% solution, we begin by anesthetizing. I do intradermal anesthesia, raise an intradermal wheel wherever I have a deployment anchor port, because you're going to be doing a little slit or a hole punch there, and obviously intradermal anesthesia wherever you're exiting. The reason for intradermal is that's where the pain fibers are. You're going from the subcutaneous space right through the skin, and you want to make sure you get those type C pain fibers and Meissner's corpuscles to ensure anesthesia. If you're doing this under local, you don't want the patient nicely relaxed, only to jump up and down every time you exit because you haven't adequately anesthetized the dermis. I then do a supraorbital block and a supratrochlear block because we're going to be dissecting some of that forehead off. The type of anesthesia I normally use under local would be one 10 milligram tablet of Valium about 1 hour before and a Vicodin about 1 hour before. This provides a nice sedative effect, and usually patients can get through that very nicely. I then go through the rest of the scalp doing my intradermal anesthesia with this 5 cc syringe, intradermal anesthesia. Most patients have their Vicodin and their Valium circulating. The other preoperative medication of importance is antibiotic. Usually I'll use a second generation cephalosporin like a Keflex, 1 or 2 tablets about 1 to 2 hours before the surgery, so there's a circulating level of antibiotic at the time of the deployment. All the intradermal points. This is one of the most painful points right here in the V2 distribution. Very painful. I don't tend to do a V2 block because the V2 block will give you a nice above the lip and central cheek anesthesia, but doesn't help you much in the lateral cheek, and you need to do tumescent tunneling anyway. So I don't want to waste my anesthesia on a V2 block. I generally use it for tumescent tunneling. I do all my intradermal anesthesia right up front to get all our exit points nice and numb, nice and anesthetized. Generally, I'll use about 7 or 8 cc's to get all my ports. Get another 30 gauge up, please, so we can just keep switching them. All our exit and entrance ports. Same with another 20, another 22 spinal. So we're doing all our entrance and exit points with nice intradermal anesthesia, nice wheel of anesthesia, and that is the exact point we should pass through when exiting or entering. We'll do our deployment and our anchor points in the temporal tuft. We'll lift the lobule up and out of the way and do our deployment and anchor point in the retrolobular area, and along the pre-cervical border, the pretracheal border of the cervical neck, our deployment and anchor point. Now that we've done all our intradermal anesthesia, if we back out, I now do my tumescent tunneling. This is the most critical phase of the procedure before deploying the needles. If you do this properly, the deployment of your articulus needle becomes simple. You must visualize the depth of the tissue that you're going to deploy that articulus needle. It's going to be in the subcutaneous space. If you hydrodissect using your 22 gauge needle in the subcutaneous plane, that is the buttery, smooth, soft layer that your articulus needle will pass through. I go through my anchor and deployment port, and I find the subcutaneous space. I slightly infiltrate and then advance. I'm in the fat or the galeal plane above frontalis. I infiltrate about 1/10 of a cc before I advance, lifting up the fat and the subcutaneous plane before I advance my needle. I try to get right down to where I'm going to be exiting, and then I infiltrate about 2.5 cc's on the way back. By doing that, you pre-anesthetize before you get hydrodissection and distension and much less pain. Again, infiltrate, I'm in the fat plane, galeal or fat plane, a small amount as I advance. As I get down to the bottom, infiltrate a tumescent tunnel of about 2 cc's, 2 to 2.5 cc's. So each track gets about 2 to 2.5 cc's of fluid. Again, hydrodissect on the way down. Make sure you're in that nice buttery fat plane, no resistance. Get down to the bottom. I'm going to switch now, and we're going to pull back, deploying 2.5 cc's of fluid. The reason I use 5 cc syringes, given my surgical mentality, if you give me 10 cc's, I'll use it up quickly. 5 cc's forces me to try and use just 2.5 cc's per tunnel. So a little more control. Slow hydrodissection, slow hydrodissection. Small amount injected before I advance the needle, and then withdraw and inject your 2.5 cc's on the way back. You can do a little bit more dissection just to your anterior border there of your careful zone, the frontotemporal line, so that you can dissect off that brow. Now we've infiltrated in a tumescent fashion the hemibrow. I will do a little bit between the two articulus thread points to allow some more brow dissection. And now we'll move on to the face. The face starts with a U-shaped, or right side up, a U-shaped loop lift using the articulus contour thread. And you get down into that temporal parietal fascia, that very, very loose areolar tissue, just above the superficial layer of the deep temporal fascia. You're sliding along that, doing hydrodissection right down to your exit and anchor point, an entrance point in the temporal tuft, right down to here. Now that took a lot more fluid, usually about 2 cc's to hydrodissect, and so now I'm going to pull back and infiltrate about 2.5 cc's along that tunnel, halfway point, come to the top, and infiltrate on the way back. So we've got a nice hydrodissection. Again, we're going to dissect on the way down in that nice areolar plane, in the temporal parietal fascia, dissect our way down, that temporal scalp, come out, go in halfway, and down to the exit point. And then withdraw and inject. withdraw and inject. That nice loose temporoparietal fascia. So we've got both limbs of our U loop lift for our articulus thread. Now we're going to go out onto the face with our N loop lifts. And we're going to go in through our deployment port and our anchor port and slowly, slowly advance, each time injecting about 0.1 to 0.2 mils of solution. I'm in that nice buttery fat plane, and I don't advance the needle till I've hydrodissected the fat off. As I get to my exit point, now I'm going to inject and hydrodissect and distend with a 2.5 cc's of fluid. Again, hydrodissect down our next trajectory right here from our anchor deployment port for the second limb of our first loop lift. Hydrodissect on the way down and then inject on the way back. If you don't have quite enough fluid, remove your syringe, add the next one, and hydrodissect on the way back. Now there's enough diffusion vertically and horizontally that allows you to do tissue dissection in this plane between the two threads without having to actually infiltrate it. Go down to your common anchor and deployment port for both the scalp loop lift, the U-shaped loop lift, and the N loop lift going out onto the face. Hydrodissect down this trajectory for this articulus thread, this limb of the articulus contour thread, down to your exit point, and then pull back and inject your 2.5 cc's. If you didn't have quite enough anesthesia, do that again and inject on the way back. If you dissect, hydrodissect with your local in the fat plane where you need to be 3 to 4 millimeters deep, your deployment will become very, very easy because you've already created the right plane for your needle. We'll talk about the depth of deployment, but you want about 3 to 4 millimeters, even 5 millimeters of fat under the dermis, as you would for a facelift flap if you were elevating it in the face. Now we're going to come under the lobule to our jawline defining anchor and deployment port. To mess that up, extend out into the jaw. Now this is very adherent over the parotid fascia and SMAS. Make sure you dissect off the fat on your way down. Stay above SMAS, not in the SMAS, and above platysma. When you get your exit point, inject on the way back and dissect that tissue off. Now I connect the two. I'm going to connect my preauricular area right here where I am going to dissect off the face between this articulus limb and this articulus limb of these loop lifts. I'm going to go into the subcutaneous space and just anesthetize the preauricular area because I'm going to be doing soft tissue dissection, lifting that off the SMAS and the parotid. So I just messed up the preauricular area where I'm going to be doing facelift microdissection flap elevation. Go under our lobule again. This time we're going to do below the jawline. Get into the subcutaneous fat above platysma. Infiltrate, hydrodissect on the way, slowly advance, get down to your exit point, and then inject your 2.5 cc's on the way back. I want to connect between the two so I can dissect aggressively over the mandible to really define the jawline border. So I'm going to infiltrate in this region right here. Little tumescent anesthesia above platysma and SMAS. Get in the right plane, slowly hydrodissect, and pull back and inject. Finally, we're going to finish with cervical anesthesia. One limb of articulus loop lift, the other limb of the articulus loop lift. Go in, inject, the tract. Stay above sternocleidomastoid. Very important here to hydrodissect off sternocleidomastoid. And if I have a pen, I will show you also external jugular. The EJ, or external jugular, often comes up here, and you need to push that down with your hydrodissection. Try to push that down. So make sure you lift off that really adherent skin over sternocleidomastoid. Come over external jugular and push that down. Push that down deeply so you pass above it. Not a disaster if you go into it, you get more ecchymosis, but won't compromise venous drainage to the neck at all. It's a superficial vein, and there's lots of deep venous structures that drain the neck adequately. And again, get in the right space above platysma and get your hydrodissection plane right out to that lateral tracheal groove where you'll be exiting for your thread lift of the neck. We've now done our tumescent anesthesia on the entire side. I have used approximately about 15 of these, 12 of these. So I have used about 60 cc's of 0.5%, which leaves me another 60 for the other side and 30 cc's to spare, given the 7 milligram per kilogram formula and 0.5% xylocaine. This completes our tumescent anesthesia. We're already seeing some nice vasoconstriction, and we're ready to start deploying our articulus contour threads and performing the loop lift. We'll perform our thread lift of the brow, our thread lift of the cheek, the jowl, and the neck in segments, so you can follow each segment as a chapter point.